All right, future pharmacists, get ready, because today we're going deep into some seriously high-yield NAPLEX territory.
Sounds exciting. What are we diving into today?
We're tackling pulmonary arterial hypertension.
Oh, PAH, a favorite. And to make it even better, we'll be covering those tricky thyroid disorders too.
You know it. And to guide us through this material, we have an expert who knows exactly what it takes to ace this exam.
Thanks for having me. Always happy to help future pharmacists conquer the NAPLEX.
I know you've helped so many students succeed on this exam. I'm excited to learn your secrets. So let's jump right in with PAH. I know this one can be tough. When you hear PAH, what's the first thing that comes to mind?
Definitely high pressures in the pulmonary arteries. It's all about that increased resistance in the lungs.
Exactly. But remember, to officially diagnose PAH, we need specific numbers.
Oh, you mean those key values like MEPP, pulmonary wedge pressure, and pulmonary vascular resistance?
You got it. Can you tell me what those values need to be for a PAH diagnosis?
Okay, so the mean pulmonary artery pressure, or MEPP, has to be at least 25 millimilli Hg at rest. Then the pulmonary wedge pressure should be 15 millimilli Hg or less. And lastly, pulmonary vascular resistance needs to be greater than 3 Wood units.
Perfect. You remembered all the numbers. It's not just high pressure, though. It's all three to really differentiate PAH from other types of pulmonary hypertension. Now let's get to the hard part. What's going on at the cellular level that causes this increase in pulmonary vascular resistance?
This is where it gets a bit more complex. I remember it's all about an imbalance. We have vasoconstrictors like endothelin trying to narrow those blood vessels.
Right, and at the same time we have those vasodilators like nitric oxide and prostacyclin trying to keep everything open and flowing smoothly.
Exactly. But in PAH, the vasoconstrictors are winning the tug of war, which leads to endothelial dysfunction, smooth muscle proliferation, and ultimately that increase in pulmonary vascular resistance that we talked about.
Spot on. And to remember those key pathways involved in PAH. Remember the mnemonic VE, V for vasoconstrictors like endothelin, E for endothelial dysfunction, and N for nitric oxide deficiency.
VEN. Gotta love a good mnemonic. So much easier to remember. Okay, so we know what's happening in the lungs, but let's talk about what this actually feels like for the patient. What kind of symptoms should make us think of PAH?
Well, I imagine it's going to be super hard to breathe, so shortness of breath, especially with activity, has to be a major symptom.
You're absolutely right. We call that exertional dyspnea. What else might you see?
Since the heart has to work harder to pump blood through those narrowed pulmonary arteries, I bet we'd see symptoms of right heart failure, like swelling on legs and ankles.
It all starts to make sense.
Yeah, it certainly does. You're thinking like a clinician. And don't forget fatigue, chest pain, and even fainting spells can occur too.
Wow, this is serious. So let's talk treatment. What's our main goal when we're managing a patient with PAH?
Well, we definitely want to improve their quality of life, make it easier for them to breathe and do the things they enjoy, and help them live longer, healthier lives.
Exactly. We aim to alleviate symptoms, improve their ability to exercise, slow down disease progression, and ultimately increase their survival.
Okay, so how do we do that? What tools do we have? Hit me with some pharmacology.
Get ready for a mnemonic that will be your best friend on the NAPLEX. PEERS.
PEERS. I like it already. Tell me more.
Each letter stands for a major drug class: P for prostacyclin analogs, E for endothelin receptor antagonists, another E for exercise and oxygen therapy, R for riociguat, which is our soluble guanylate cyclase stimulator, and S for sildenafil or tadalafil, which are our PDE5 inhibitors.
PEERS. Easy to remember. It's like a support group for managing PAH.
I love it. Let's start with P, the prostacyclin analogs.
Excellent choice. Now, these are potent vasodilators, and some of them have even been shown to improve survival. Epoprostenol is one of the stars of this group.
I remember epoprostenol. It's given IV, but has a really short half-life, so it needs to be continuous infusion, right?
You're exactly right. Not the easiest drug to manage. What are some side effects we need to be aware of with epoprostenol?
It can cause flushing, jaw pain, headaches, and hypotension.
And I think there was a pretty serious black box warning for epoprostenol, too.
Yes. Risk of rebound PAH if it stopped suddenly. Definitely something we need to counsel patients about.
Absolutely. Now, another important prostacyclin analog is treprostinil. What can you tell me about this one?
Treprostinil is pretty versatile. It's available 5E, subcutaneously, inhaled, and even oral.
That's right. You really know your stuff. Now, how do the side effects of treprostinil compare to epoprostenol?
They're similar, but instead of jaw pain, we see infusion site pain with the subcutaneous route. Headaches and diarrhea are common too.
Excellent. And treprostinil has a black box warning as well. For intravenous administration, there's a risk of bloodstream infections.
Okay, so we've got two powerful prostacyclin analogs there. Epoprostenol and treprostinil, both potent, both with some serious side effects and black box warnings. What's next in our PEERS group?
Let's move on to E-endothelin receptor antagonists, ERAs for short.
Ah, yes, those endothelin blockers. Got to keep those vasoconstrictors in check.
Exactly. Which ERAs should we know for the NAPLX?
There's three main ones: bosentan, ambrisentan, and macitentan.
Excellent. Tell me a little about bosentan.
Bosentan blocks both types of endothelin receptors, making it a dual ERA. It's known to improve exercise capacity, which is a big plus for our PAH patients.
Right. Now, what are some side effects we need to remember for bosentan?
Well, hepatotoxicity is a concern, so we need to monitor LFTs. Anemia is a potential side effect as well.
Excellent recall. And what's the black box warning we need to know for bosentan?
Bosentan has a black box warning for both hepatotoxicity and teratogenicity. It's important to counsel patients of childbearing potential.
Absolutely. Now, let's talk about ambrisentan. What can you tell me about that one?
Ambrisentan only blocks one type of endothelin receptor. It's a selective ERA. It can cause peripheral edema and nasal congestion.
Great. And last but not least, tell me what you remember about macitentan.
Macitentan is another dual ERA like bosentan. It's been shown to actually reduce morbidity and mortality, which is really impressive. But it can also cause anemia and nasopharyngitis.
Excellent summary. All three ERAs, bosentan, ambrisentan, and macitentan, carry that black box warning for teratogenicity. So remember to emphasize that risk to your patients.
Wow. ERAs are effective, but they definitely come with some serious risks, especially for pregnant women. It's a good reminder that every medication has potential benefits and risks.
Exactly. That's why understanding these details is so crucial for the NAPLEX and for your future practice as pharmacists. Now, we've talked about P and E in our peers mnemonic. What about that second E?
That one's for exercise and oxygen therapy. It's a reminder that lifestyle modifications are super important for managing PAH.
Absolutely right. Encourage your patients to exercise regularly, of course within their limits, to help improve their functional capacity. And supplemental oxygen can really help those patients struggling with shortness of breath.
So it's a holistic approach, medications plus lifestyle modifications. Now, on to our riociguat. What's special about this drug?
Riociguat is a soluble guanylate cyclase stimulator. It works by enhancing the effects of nitric oxide, which helps to dilate those blood vessels.
You explained that perfectly. Now remember, riociguat can cause hypotension and increase bleeding risk, and don't forget the black box warning.
Right. Riociguat also has a black box warning for teratogenicity, and it's contraindicated with PDE5 inhibitors.
Which leads us nicely into the S in pure sildenafil and tadalafil.
That's right. These are our PDE5 inhibitors. They increase levels of CGMP, which causes vasodilation. They might sound familiar. Viagra and Cialis.
Right, I remember them. They can cause headaches, flushing, and dyspepsia.
Great. What's the big drug interaction to remember for PDE5 inhibitors?
The one with nitrates. Absolutely cannot give PDE5 inhibitors with nitrates. It can cause dangerously low blood pressure.
Got it. That's definitely one to remember. Now, I think we've covered most of our peers. But is there another drug class we need to know about for PAH?
You're right, we can't forget about calcium channel blockers. Now, these aren't usually first line for PAH, but they have a special place in our treatment algorithm. They're reserved for patients who have a positive vasoreactivity test.
Right. That's the test done during right heart catheterization to see if the patient's pulmonary arteries relax in response to certain medications. And if they do, it suggests that calcium channel blockers might be effective.
It's all about finding the right treatment for the individual patient. So we've talked about all these PAH medications, but how do we put it all together? What's the treatment approach?
Great question. The first step is confirming the diagnosis with right heart catheterization. Then we do that vasoreactivity test. If it's positive, we try calcium channel blockers. But if the test is negative, or if the patient doesn't respond well to the calcium channel blockers, then it's time for our peers.
So we individualize the treatment plan for each patient, like putting together a puzzle. Professor, before we dive into thyroid disorders, can we try some practice questions to test what we know about PAH?
Of course. Let's start with this one. A patient with PAH is starting bosentan. What monitoring is absolutely essential?
Bosentan is an ERA, and those have a black box warning for hepatotoxicity. So monitoring liver function tests is essential.
Nailed it. Regular monitoring of liver function tests is super important for patients on bosentan. Try this one. Which of the PAH medications we talked about has actually been shown to improve survival in clinical trials?
Let me think back to our peers. It was one of the prostacyclin analogs. Was it epoprostenol?
Excellent recall. Epoprostenol is the one that's been proven to improve survival in studies.
This is great. I feel much more confident about PAH. Now, are we ready to move on to thyroid disorders?
Ready when you are.
All right. Let's dive into the world of hypothyroidism. What's the defining feature of hypothyroidism?
Hypothyroidism means the thyroid gland isn't producing enough thyroid hormone.
Precisely. And how do we confirm that diagnosis? What lab values are we looking at?
We need to check the TSH and free T4. In hypothyroidism, we'd see an elevated TSH and a low free T4.
Perfect. Now let's talk about symptoms. Hypothyroidism can be a bit tricky because it can mimic other conditions. So how can we remember the key clinical features? Well, I have a handy mnemonic for you. Mom's so tired.
Okay, I'm intrigued. Tell me more.
So the M can stand for memory loss, which is common in hypothyroidism. O is for obesity, another frequent finding. And then we have another M for menorrhagia, or heavy menstrual bleeding. The first S is for slow speech and slow reflexes, and the second S is for skin dryness. O, again, is for onset, which is gradual. It often develops really slowly.
Wow, that's a lot packed into just moms. What about so tired?
Okay, so T is for tiredness, one of the classic symptoms. I is for intolerance to cold, another telltale sign. R stands for raised blood pressure, which can sometimes occur. E is for energy levels falling, and D can stand for both depression and delayed relaxation of reflexes.
Mom's so tired. That covers every symptom I can think of. So once we diagnose hypothyroidism, what's our treatment?
The treatment algorithm is pretty straightforward. First, we confirm the diagnosis with TSH and free T4 levels. Then we start levothyroxine therapy.
Levothyroxine, that's synthetic T4, right? So we're basically just replacing what the thyroid gland isn't producing.
Exactly. The starting dose depends on the patient's age and if they have any heart problems. For younger patients under 60 without coronary heart disease, we usually start with 1.6 mg/d a day. For those over 60 or with heart disease, we start a bit lower, maybe 25 to 50 mg/d a day.
So age and heart health matter when choosing the starting dose. What happens after we start the levothyroxine?
We recheck the TSH in 6 to 8 weeks. The goal is to get that TSH back to normal. We adjust the dose, usually in increments of 12.5 to 25 milligrams, until we achieve that. And then once the patient is stable, we just monitor them annually with a TSH check.
Makes sense. Now, are there other medications besides levothyroxine for hypothyroidism?
There are. Levothyroxine is definitely our go-to. It comes in a few different brands like Synthroid, Levoxil, and Tirosint. But there's a few key things to remember about levothyroxine.
Like what?
Well, we need to think about potential side effects. Since we're giving thyroid hormone, too much can lead to symptoms of hyperthyroidism.
So things like palpitations, rapid heart rate, tremors, insomnia, and maybe GI issues like diarrhea and vomiting.
Exactly. And we monitor for that by checking those TSH and free T4 levels. Another important point, different brands of levothyroxine are not bioequivalent.
Wait, really? I didn't know that.
Yep, switching between brands can change thyroid hormone levels even if the dose stays the same.
So consistency is key. What about liothyronine? Do we use that one often?
Liothyronine is synthetic T3. It's not usually the first choice for hypothyroidism, but we do sometimes use it with levothyroxine for patients who don't feel completely better on levothyroxine alone.
Interesting. So it's more like an add-on option. Are the side effects the same as levothyroxine?
Similar, but they can be a bit more intense because T3 is stronger and acts faster. When we use liothyronine, we monitor TSH, free T3, and free T4.
Okay, got it. What about desiccated thyroid extract? Have you ever had patients ask about that?
Oh, you'll definitely be asked about that on the DTOLX, so pay attention. Desiccated thyroid extract comes from animal thyroid glands, so it contains both T4 and T3. The problem is the ratio of T4 T3 is not always the same, so it's hard to keep the levels consistent.
I see, so it's less predictable. What about side effects?
They're similar to levothyroxine, but we have to think about those fluctuating T3 levels. Okay, so to sum all that up, levothyroxine is our mainstay, liothyronine is an add-on option, and desiccated thyroid extract is less preferred because the ratio of T4 to T3 can be inconsistent. What else should we know about hypothyroidism? Couple more tips. We always want to counsel our patients on how to take levothyroxine correctly. It's best taken on an empty stomach at least 30 minutes before breakfast.
Good point. What about pregnancy? Are there any special considerations?
Pregnancy increases the need for thyroid hormone, so often we need to increase the dose of levothyroxine during pregnancy.
Makes sense. Any drug interactions we need to be aware of?
Oh, definitely. Certain meds like amiodarone, lithium, and tyrosine kinase inhibitors can affect thyroid function. It's important to monitor thyroid levels when those are started or their doses change.
Okay, great reminders. Before we move on to hyperthyroidism, is there a trick for remembering levothyroxine doses?
There is. It's a bit long, but super helpful once you learn it. It goes like this. Gigantic, powerful, lavish, big, teal, brawny, rosy, youthful, olive-sized, vibrant, wee, tiny.
Wow, that's a mouthful. How does that translate into doses?
Each word is for a specific dose, starting with 300 milligrams for gigantic and going down to 25 milligrams for tiny. So for example, big is 150 milligrams, rosy is 112 milligrams, and olive-sized is 88 milligrams.
That's clever. Okay, I think we've covered hypothyroidism pretty thoroughly. Are we ready to tackle hyperthyroidism?
Let's do it. So hyperthyroidism is the opposite of hypothyroidism. What's going on in this condition?
In hyperthyroidism, the thyroid gland is overactive. It's producing too much thyroid hormone.
Exactly. How do we diagnose it with lab tests?
We would see a low TSH with high free T4 and high free T3, basically the reverse of hypothyroidism.
You got it. Now let's talk about those symptoms. Hyperthyroidism has a lot of unique signs and symptoms. Another mnemonic for you, sweating.
Okay, let's hear it. I love mnemonics.
Okay, so S stands for sweating, which happens a lot in hyperthyroidism because of that increased metabolism. W is for weight loss. E is for emotional ability, so lots of mood swings. A is for increased appetite. The body is burning more calories. T is for tremor and tachycardia, which go along with that overactive state.
I'm getting anxious just hearing about these symptoms. What about ING?
I covers intolerance to heat, irregular periods, and irritability. N is for nervousness, and G is for goiter and GI problems like diarrhea.
Sweating, that's a good one. I'll remember that. How do we manage these patients? What's the treatment strategy?
First, we need to confirm the diagnosis, so we'll check those TSH, free T4, and free T3 levels. And then we need to figure out what's causing it. Is it Graves' disease, a toxic nodular goiter, or something else? The cause will really guide our treatment choices.
Personalized medicine.
Yeah.
So what are the treatment options?
For Graves' disease, which is the most common cause, we usually start with antithyroid drugs. If those don't provide long-term control or the patient can't take them, then we might consider radioactive iodine or surgery, a thyroidectomy.
Okay, so antithyroid drugs first. Can you tell me about those?
The two main ones are methimazole and propylthiouracil, PTU for short. We typically start with methimazole. It's generally preferred over PTU. But PTU is useful in certain situations, like during the first trimester of pregnancy or to manage thyroid storm, which is a dangerous complication.
I see. Why is methimazole usually preferred?
Methimazole has a better safety profile overall, and it's taken once a day. It makes it easier for patients to stick with the treatment.
Okay, what are the key things to know about methimazole?
It comes as the brand Topazole, and we usually start with a dose between 10 and 30 milligrams daily. The common side effects include things like rash, itching, and joint pain. There are rare but serious side effects too. Granulocytosis, which is a low white blood cell count, and hepatotoxicity or liver damage.
Those are scary side effects. How do we monitor for them?
We check complete blood counts, CBCs, and liver function tests. And of course, we're also watching those TSH and free T4 levels to make sure the medication is working. And another key point for the NAPLEX, methimazole has a black box warning for granulocytosis.
Another black box warning. It seems like there's so many to remember.
I know it can feel overwhelming, but these are the important details you need to know to keep your patients safe. So methimazole is effective, but it has risks. What about PTU? PTU works the same way as methimazole, but it's dosed more often, usually every 8 hours. The side effects are pretty similar, but PTU has its own black box warning.
Let me guess. Another serious risk.
You got it. PTU has a black box warning for severe liver injury and acute liver failure.
That's definitely something to take seriously. We have these two good antithyroid drugs, but both have some pretty serious risks. Anything else we need to remember about treating hyperthyroidism?
Don't forget about beta blockers. They can help manage some of those symptoms like a racing heart and tremors. Propranolol and atenolol are good choices.
Right, they help patients feel better while we're working on fixing the thyroid issue. What about iodine solutions? Do we use those sometimes?
Good catch. Iodine solutions like Lugol's solution or potassium iodide can be helpful in specific situations. For example, to prepare for surgery or during thyroid storm. They help decrease thyroid hormone production. But we use them for short periods only because of a side effect called iodism.
What is iodism?
It causes a metallic taste in the mouth and a lot of salivation. Definitely not fun for the patient. Okay, anything else?
I think we've covered a lot. Pregnancy always comes to mind.
Yeah.
Anything special about hyperthyroidism in pregnancy?
Absolutely. Methimazole is typically avoided during the first trimester. There's a risk of birth defects. PTU is generally considered safer during that time, but often will switch back to methimazole after the first trimester. Radioactive iodine is absolutely contraindicated in pregnancy and breastfeeding, of course.
Right, that makes sense. Are you ready to test our knowledge with some practice questions on hyperthyroidism?
Let's see what you've learned. First question. A patient on levothyroxine 100 milligrams daily for hypothyroidism has a TSH of 0.2 MIUL. What should be done?
Let me think. TSH is low, which means they're getting too much thyroid hormone. They're over-replaced. We need to decrease the levothyroxine dose.
Right on track. Recognizing over-replacement is important. Next question. Which of the following is a contraindication to methimazole in hyperthyroidism?
This one's tricky. Let me see. Methimazole. I remember something about pregnancy. Methimazole is contraindicated during the first trimester.
You remembered. Great job. Okay, one more scenario. A patient with hyperthyroidism is taking methimazole and tells you they have a fever and sore throat. What's the most appropriate action?
Fever and sore throat. That could be an infection, but methimazole has that black box warning for granulocytosis. I would stop the methimazole right away and check their white blood cell count with a CBC.
You're absolutely right. You need to act quickly if you suspect a granulocytosis. Okay, before we move on, any final words of wisdom about hyperthyroidism? Just a few key takeaways for the NAPLEX. Know those normal ranges for TSH, free T4, and free T3. And that negative feedback loop in the hypothalamic pituitary thyroid axis, super important for understanding how thyroid disorders work.
Got it. That negative feedback loop is key. Anything else?
Know those drug interactions that affect thyroid function. We talked about a few. Amiodarone, lithium, oral contraceptives. And remember, subclinical thyroid disorders, that's when TSH is abnormal, but the free T4 is normal.
No, they're sneaky.
They are. Finally, always think about special populations like pregnant women and elderly patients. They often have unique needs.
Great points. Professor, this has been so helpful. Thanks for all the insight. What's next?
Let's do a few more practice questions. We'll cover both PAH and thyroid disorders, just to make sure you're ready to conquer the NAPLEX. Ready for one last knowledge check.
Bring it on.
Okay, first question. Which PAH medication should be avoided in patients taking PDE5 inhibitors?
Okay, let's see. Thinking back to our mnemonics, it was riociguat. It's contraindicated with PDE5 inhibitors.
Right again. Looks like you've mastered those drug interactions. Okay, another one. Which medication can cause both hypothyroidism and hyperthyroidism?
We talked about a few drugs that can mess with thyroid function. I think it was lithium.
That's right, lithium can do both. Last one. Which thyroid condition is associated with high free T4 and high free T3?
That's hyperthyroidism. Easy one.
You aced our review. You're definitely going to rock the NAPLEX.
Thanks for the confidence boost. I feel so much more prepared now.
That's what I like to hear. But remember, this is just the beginning. There's always more to learn. The world of pharmacy never stops changing. So stay curious and never stop learning.
Great advice. I think it's time to wrap up this part of our deep dive.
Sounds good to me. Ready for a break?
Absolutely. Let's take a quick break and come back for more NAPLEX prep.
All right, let's get back to hyperthyroidism and talk about the treatment. You already mentioned some of the key medications, but can you walk me through how we manage a patient with hyperthyroidism?
Sure. First, we confirm the diagnosis.
Right, we need to be sure.
So that means checking those thyroid function tests. The TSH, free T4, and free T3.
Exactly. We need to see those lab values. What's next?
We got to figure out what's causing it. Is it Graves' disease or a toxic nodular goiter? Something else. The cause is going to determine our treatment plan.
Absolutely. It's all about personalized medicine. So let's say it is Graves' disease. What's our first line treatment?
For Graves' disease, we usually start with antithyroid medications to decrease thyroid hormone production.
You got it. You mentioned the two main ones, methimazole and propylthiouracil. Can you remind me how those work?
They inhibit the enzyme thyroid peroxidase.
Right, which is needed to make thyroid hormone.
So by blocking that enzyme, we can lower those high thyroid hormone levels.
Excellent explanation. Let's dive into the specifics of each medication. Let's start with methimazole. What are the key things to remember about methimazole?
Methimazole is generally preferred over PTU.
And why is that?
It has a better safety profile, and it's only once-a-day dosing.
Right, so it's easier for patients to take. Now, what about those side effects?
We see rash, itching, joint pain.
Those are the common ones? What about the less common but more serious ones?
Right. There's a granulocytosis and hepatotoxicity.
Excellent recall. And what's that important black box warning for methimazole?
The black box warning for a granulocytosis.
Right. We have to watch our patients closely for that, especially early on.
It's incredible how much information pharmacists have to know about these medications.
It really is. It's not just memorizing facts, though. It's understanding how they work and when to use them.
That's what makes it so challenging.
It is challenging, but that's what makes it so rewarding. Now let's talk about PTU, propylthiouracil. When do we choose PTU over methimazole?
I remember that PTU is often used in the first trimester of pregnancy.
That's right, because methimazole has that risk of birth defects.
And it's also used for thyroid storm.
You nailed it. Now what about side effects to remember for PTU?
Similar to methimazole, rash, itching, joint pain. But PTU also has a black box warning.
Another one.
Yes. This one is for severe liver injury and acute liver failure.
2 antithyroid drugs, 2 black box warnings. It's a good reminder to watch our patients closely.
Couldn't agree more. Patient safety is our top priority. Now, before we move on, let's talk about a couple more medications that could be helpful for hyperthyroidism. You mentioned beta blockers earlier. Why might we use those?
Beta blockers like propranolol and atenolol help with the symptoms of hyperthyroidism.
Right, like that racing heart and tremors.
Exactly. They don't lower the thyroid hormone levels.
That's a key point. They just make the patients feel better while we're treating the root cause. Now, what about those iodine solutions? When are those used?
Iodine solutions like luteal solution or potassium iodide, we use them sometimes for thyroid storm and before thyroid surgery.
Right, to reduce thyroid hormone production.
But only for short periods because of that side effect, iodism.
Excellent. You remembered iodism can cause a metallic taste and too much saliva. Not pleasant. Okay, before we do practice questions, any other pearls of wisdom about hyperthyroidism?
We need to remember that radioactive iodine can't be used during pregnancy or breastfeeding.
Good point. Anything else?
Drug interactions. We have to think about medications that can affect the thyroid, like amiodarone, lithium, and those oral contraceptives.
Those are all important points. You clearly understand how to manage hyperthyroidism. Now, are you ready for some practice questions?
Absolutely.
All right, here's the first one. A patient with hyperthyroidism is on methimazole and develops a sudden fever, sore throat, and mouth sores. What do you think?
Fever, sore throat, mouth sores. Could be an infection, but with methimazole, I'm thinking a granulocytosis. It could be a sign their white blood cell count has dropped.
Exactly. You know what to look for. What would you do?
I'd tell the patient to stop the methimazole and see their doctor immediately. Better safe than sorry.
Good call. You understand how serious a granulocytosis can be. Here's another one. A patient with Graves' disease has been taking methimazole for 6 months, and their thyroid function tests are now normal. What's the next step?
If their thyroid function tests are normal, it sounds like the methimazole is doing its job. We would continue the medication and monitor their thyroid levels regularly.
That's exactly right. We want to keep them in that sweet spot where their hyperthyroidism is controlled, but they're not at risk for side effects. One last question. A pregnant patient in her first trimester is diagnosed with hyperthyroidism. What do we do?
Tricky one. We can't use methimazole in the first trimester because of the risk of birth defects, so PTU would be the safer option.
You got it. You've done a great job navigating the ins and outs of hyperthyroidism.
Wow, we've covered so much already. I feel like a thyroid expert now.
That's the goal. But remember, this is just the beginning. Always keep learning.
True. Should we do a quick review of those mnemonics before we move on? Those are going to be so helpful in the NAPLEX.
Good idea. Mnemonics are like our secret weapons. Let's start with PAHs for those PAH medications. Can you remind everyone what each letter stands for?
PAHs is for prostacyclin analogs, endothelin receptor antagonists, exercise and oxygen therapy, riociguat, and sildenafil or tadalafil.
Perfect. And don't forget VN for remembering the key pathways involved in PAH. Vasoconstrictors like endothelin, endothelial dysfunction, and nitric oxide deficiency. Okay, let's review our mnemonics for thyroid disorders. Mom's so tired was for hypothyroidism.
That one really stuck with me. It's so comprehensive.
It is. Let's break it down one more time. M for memory loss, O for obesity, M for menorrhagia, S for slow speech and reflexes, S for skin dryness, O for gradual onset. And then tired reminds us of tiredness, intolerance to cold, raised blood pressure, energy levels falling, and depression. Now, how about sweating for hyperthyroidism?
Sweating stands for sweating, weight loss, emotional lability, increased appetite, tremor, and tachycardia. The ING is for intolerance to heat, irregular menstruation, irritability, nervousness, goiter, and GI problems.
Wow, those mnemonics are so helpful. They paint a clear picture of each condition.
Exactly. But remember, they're just tools to help us remember the key points. The real learning comes from understanding the concepts behind them. But those little memory tricks can be lifesavers, especially during a tough exam.
So true. Well, Professor, are you ready to put our listeners to the test with a few final practice questions?
Let's do it. Let's see what you've learned today. Ready for a final knowledge check, listeners?
Hit us with your best shot.
Okay, first question. What is the first-line treatment for patients with a positive vasoreactivity test in PAH?
Positive vasoreactivity test means that the patient's pulmonary arteries relax when given certain meds. So the first-line treatment is calcium channel blockers.
Right on. Next question. Which PAH medication is given orally and acts as a prostacyclin receptor agonist?
Orally, and a prostacyclin receptor agonist. It's not epoprostenol, that's IV. And bosentan is an ERA. Riociguat is a soluble guanylate cyclostimulator, so it must be Selexipag.
You got it. Selexipag it is. Okay, one more PAH question. What is a common side effect of those prostacyclin analogs?
Prostacyclin analogs are vasodilators, so I'd expect to see side effects related to that, like flushing and headache.
That's right. Okay, now onto those thyroid disorders. A patient comes in with fatigue, weight gain, and cold intolerance. What lab test do we order first?
Fatigue, weight gain, and cold intolerance. Those are classic hypothyroidism symptoms. We need to check a TSH level.
Yes, TSH is our go-to test for hypothyroidism. All right, next question. Which medication can cause both hypothyroidism and hyperthyroidism?
A medication that can cause both. Thinking back to those drug interactions. Was it amiodarone?
You are correct. Amiodarone can affect the thyroid in both ways. Okay, last question. Which thyroid condition has high free T4 and high free T3?
That's hyperthyroidism.
That's it. You aced our review. I think you're ready for the NAPLX.
Thank you so much. This was so helpful. I feel much more confident about all these topics.
That's great to hear. But remember, the NAPLX isn't just about knowing the facts.
Right. It's about applying what you know to patient care.
Exactly. Think about yourself in a pharmacy, working with real patients. How would you use what we talked about today to help them?
That's such an important point.
And don't forget to work with the other healthcare professionals, your doctors and nurses. It takes a team to take good care of patients.
Absolutely. It's all about teamwork.
And never stop learning. Pharmacy is always changing. Stay curious and stay up to date.
I love that. Always keep learning. But I think it would be good to leave our listeners with something to think about. What's one last thought-provoking question for our future pharmacists?
That's a great idea. We talked about those subclinical hyperthyroid cases where the TSH is abnormal, but the free T4 is normal. So here's a challenge. What factors might lead you to treat subclinical hypothyroidism, even if the free T4 is normal?
That's a good one. I'm thinking about the patient's age and if they have other medical problems and if they're having symptoms, even though their labs look okay, and of course what they want to do.
Right, it's not always just about the numbers.
Exactly.
Yeah.
Sometimes it's about the whole picture. Using your judgment as a pharmacist, thinking about each patient as an individual, and balancing those benefits and risks of treatment, that's what makes pharmacy such a great profession.
Well said, Professor. To all our future pharmacists out there, keep studying, stay curious, and never stop learning. We'll see you next time on The Deep Dive for more exciting topics from the world of pharmacy.